So hi, you're not Ruth.
Sorry.
Sorry, Becca. Thanks, Becca, not Ruth. Yeah, you told me that.
That's okay.
Okay, so hello everyone. My name's Andy Ward. I'm just going to try and move this slide on. Zoom's doing that weird thing where it gets in the way of everything. Okay, so as Rebecca said, my name's Andy Ward. I'll just introduce myself before I do the talk. I'm a salary GP and I work at Inclusion Healthcare in Leicester, which is a specialist practice. Some of you may have heard of it. We look after people experiencing homelessness and also people who are going through the asylum seeker process in the Leicester area. We've got about 800 patients registered as homeless, and they're people who have insecure housing rather than sleeping on the streets particularly. And we have about 1,200 to 1,400 asylum seekers registered at the moment in the practice. I've been working there for a couple of years. I have worked in the North Hampshire area in the past. I'm also working at Leicester Medical School, where I'm associate professor of medical education there. I worked there 18 years now, and I'm part of an initiative there called the Stonygate Centre for Empathic Healthcare. And what we're trying to do there is get as much empathy as possible into our medical students so that they are more empathic when they leave medical school than when they join. And actually, at the moment, unfortunately, the opposite is true. I'm trying to reverse that. And I was just saying to Becca, I'm also a presenter for NB Medical, and I do the hot topics things. And I've done a talk on migrant health, which I've developed today, which I'm going to do for you just now. And there's my email address. If anyone has any questions, I'll put the email address up at the end. If I don't manage to answer the questions tonight, drop us an email. I'm very happy to answer that for you. So what we're going to do this afternoon, and I'm actually shamelessly stolen most of the resources in this presentation from these really helpful organisations. Doctors of the World, a really good charity. They work nationally, internationally, helping doctors who work with asylum seekers and refugees to do a better job. So they're a great service. The assist practice where I work is the asylum seeker side of it, and I've nicked some resources they produce. Refugee Council have got a really good website, loads of information and advice you can use. And the government website, for once, is really good. So the Migrant Health Guide on the government website is exactly very, very helpful. If you get stuck, I'd recommend going to that. What we're going to go through, I'm going to go through a little bit of background around migrant health and the situation that we're seeing in the UK at the moment. A little bit about the entitlement to healthcare in the UK. There's lots of misunderstandings around that. Some common health problems that you'll find with refugees, migrants, asylum seekers. If we have time, hopefully we will, a bit about how to work effectively with interpreters, which is a big part of migrant health. And we probably won't have time for post-traumatic stress disorder, but if we do, I'll go through that as well. So just to get some thoughts from the group, and you can use the chat for this, and I'll open the chat box so I can see that. What goes through your mind, honestly, and you can be honest, when you think about having to care for a migrant or a refugee, and also what would you feel if you knew that in your practice area where you work now, a large number of asylum seekers, and Becca's just telling me this is likely to happen where she is, were suddenly going to be housed in the area where you're working. Just put some comments in the chat about what that would make you think if that was coming to you. And while you're doing that, would you mind muting as well? Because I'm getting a little bit of echo. So if you're not muted already, if you just could do that, that'd be really good. So just put some comments there. I remember when I was a GP, I've been a GP for 25 years now, and when the Kosovo war was going on, suddenly we got a phone call saying there's a busload of Kosovan refugees that come into your practice there tonight. Can you see them all? And it was slightly panicking inducing. So just put some comments in there, just see if anyone puts that in there. Okay. So we'll carry on. We'll keep typing those. I'll carry on speaking, so I don't want to run out of time, and we'll come back to some of those comments a bit later on. Come to the screen. Okay, so let's go through a little bit of background here. So some definitions. This is always helpful because these definitions are often incorrect when used by the media, and so it's useful to have them explained really with a bit of clarity. So a refugee, that's someone who actually has come to the UK and has claimed asylum and actually has been successful. So they've been granted asylum to stay in the UK. The system has decided that they are not safe in their home country and they should be allowed to stay. So that's a refugee. And these terms are often used interchangeably, particularly by the media, but also by the public and doctors as well. An asylum seeker, that's someone who's come to the UK or left their country of origin because they don't feel safe, and they put in an application for asylum on arrival, but that has not yet been concluded. And they have very different rights to a refugee. So no decision has been made yet. They're waiting for that decision. A refused asylum seeker is somebody who has been put in an application for asylum and that's been unsuccessful. And I'll talk a little about the numbers of people who that applies to. And they have also a different amount of rights to the asylum seekers and refugees as well. They're in a different situation to the others. And then an undocumented migrant, and these are the ones that the newspapers like to talk about. These are people who tend to talk about undocumented migrants or illegal immigrants is a common phrase that you might hear. Usually when they use that term, they're actually talking about asylum seekers who are not illegal immigrants, but they use that term. An undocumented migrant is someone who's here who shouldn't be here. So that's someone who's perhaps been on a work visa and that work visa has expired and yet they've stayed in the UK. Maybe a refused asylum seeker who's just disappeared, which often they do if they lose their asylum case, or someone who's travelled to the country illegally. Quite a small number of people fall under that category. They may have forged documents or something like that, so they're a non-documented migrant. So those terms are often used interchangeably by the media and by people who don't understand them, and it can cause problems when it comes to their entitlements to healthcare, etc. So I'm going to go through a bit of a scenario just to give you some facts and figures around where we are with migrant health and what the situation is like for patients who are affected by that. So Arif is from Syria. Here he is. Before the Civil War, he planned to go to university. He wanted to become an English teacher. And then when the soldiers came to his house, they tried to force him to join the army as a young man and fight in the war there, and threatened to kill anyone who refused to join the fight. So he decided the best thing to do was to leave his family, leave the country, and he fled to Lebanon. And actually, the majority of refugees and asylum seekers are in the next door country to the country they come from. So 86% of the world's refugees only cross one border. Again, quite different to the picture you'd expect when you read the media. In Lebanon, it's often the case he was abused, he was assaulted, he didn't feel safe. People realised he was from Syria and they didn't want him there. And he decided to leave and try and get to the UK. And the reason he wanted to come to the UK was not because of the NHS or the benefits agency, it's just he could speak English and he wanted to be able to be in a country where his English use would be helpful. The UK is home to 1% of the world's refugees. You think 86% of the world's refugees are in neighbouring countries, 1% in the UK. So it's actually unusual for people to make that decision to come to the UK. As he made his journey, he was looking at the people around him and saw a lot of children. 42% of displaced people around the world are actually children. So it's a huge number of people affected by this are children. Quite a sobering thought, really. And he gets to the UK, and it's a pretty horrendous journey, as you can imagine, to get there. And when he arrives in the UK, as a single man, he's placed in a detention centre. And I think that's the place you might be talking about, Becca, that's coming in your local area. This is somewhere where they put single men, and it's actually basically a bit like a prison, and it looks like a prison. They're often converted military barracks, or Air Force bases. And when you think that actually quite a lot of the people who leave their home country are doing so because they've been abused by military people, by soldiers, they may have been taken into military bases and tortured or in prisons, and they arrive in the UK and they're put into a military base with big high gates like this. You can imagine that's quite traumatic for people. There is no healthcare provided as such in these centres. They only provide acute physical and mental health care. There's no chronic disease management. There are only nurses who work in these centres. No doctors work there. So the medical care is not great. And we saw recently with outbreaks of infections in these areas, which you can imagine would be quite difficult to manage. As part, the next step is they actually make a claim for asylum. So Arif makes his claim for asylum. They then go to what's called intake unit, where they're interviewed and processed and their asylum claim is considered. As part of that, they should be considering medical and safeguarding issues. So is this someone who has a long-term medical problem, or is this someone who has safeguarding issues that need to be flagged up? And they should be passed on to any healthcare provider. After that interview, they'll often be moved to their initial accommodation. In our case, this would be a hotel. He was moved to a hotel in Derby, and you probably heard a lot in the media about asylum seekers living in hotels. And he stayed there for 3 months, and then suddenly, with 24 hours notice, he was moved to Leicester to what we call his dispersal accommodation. This is a house shared with other asylum seekers from different countries. Didn't know any of the people there, didn't speak any of their languages. Whereas when he was in Derby, he did know some of the Syrian people as well. He was told to register with a local GP service, and people, the asylum seeker organisations should be ensuring that all asylum seekers are registered with a GP. He's given £45 to live on whilst he's in the house. Those asylum seekers living in a hotel are given about £8 a week to live on because their meals are provided. And most asylum seekers actually live in poverty. They are not allowed to work in the UK at all while they're seeking asylum. So they just have to live off that £45 a week. They can't buy basic clothing, food, powder milk, nappies for children. It's very, very difficult to live on such a small amount of money. And obviously that then leads to perhaps abuse of the system. You often end up, you see our asylum seekers might end up working in factories when they're not supposed to be, or in car washes are a common source of people to work there, being paid less than minimum wage, working long hours. Women are obviously subject to more difficult abuse, and sexual violence is very common with female asylum seekers. It then ends up in the asylum process. This is very, very complicated. We had about 75,000 applications in the last year. That's quite significantly higher than the year before due to the small boats that are coming over at the moment, but it's only the 6th highest in Europe and the 22nd per head of population. So we're quite behind countries like Germany and France. 20,000 of those were granted status in the last 12 months. And over 170,000 people are waiting for a decision on asylum, whether they're allowed to stay in the UK as a refugee in March. None of them are allowed to work. All of them are living in accommodation paid for by us as taxpayers, and the backlog is pretty significant at the moment. 53% of, so about 74% of the initial applications are granted. So that's a significant amount. Again, if you believe the media, most people come here shouldn't be here, but actually 75% of them are being granted asylum immediately. And then 53% of those who refuse asylum on the first attempt are granted asylum on appeal. So we're left with quite a small number of asylum seekers who are not granted a refugee status, but over 80,000 have been waiting for more than 6 months, and thousands of these people are waiting years to find out whether they can be allowed to stay in the UK, and completely rely on the courts and that complicated legal process. We go back to Arif again. After 9 months, he's granted refugee status, which you'd think would be a cause for celebration, but it's only for 5 years. So after 5 years, you've got to go through the whole process again. So it's really difficult for him to try and put down roots, try and get a career, try to go to university, maybe train to be a teacher as he wanted to. He knows he's going to go through this terrible process again. His support is stopped. He's no longer asylum seeker, so he's no longer entitled to accommodation. He's no longer entitled to those payments. He's getting that £45 per week. He has to get a job, find a house, and also all claim benefits. It doesn't stop immediately. They get about 4 weeks grace to find somewhere to live. He can't find anywhere to live. He ends up homeless. He's waiting to sign up for benefits. He's relying on charities to support him. There's no transition cover in this period, and he's left on the streets, basically worse off probably than he was in Syria. And the practice I work at, we're only allowed to register asylum seekers in the asylum seeker practice. When they get refugee status, they have to re-register with a normal mainstream GP. They often come and register on our homeless side as soon as they get their refugee status, because they become homeless, and it's a scandal, really. Well, there we go. So that's a little bit of background. Has anyone got any questions at this point before I move on to the next bit about any of that? Is that some of the question? I can. Hello? Okay. Again. Hi, Joel. Have you got a question for me? I think you've got your microphone off mute at the moment. No. Okay. No questions. Okay. Let's move on. So Next thing I'm going to talk about now is entitlement to healthcare in the UK. And I want to ask you a question first. So I'm going to ask you to interact a little bit with me now, use the chat. So which of the following are required to register with a GP in the UK? So do you need proof of address? A, photographic ID. B, an NHS number. Proof of British nationality, or proof of leave to remain in the UK, or all of the above. So if you want to put in the chat, just write the letters in there, what you think is right, and we'll see if you get it. A to C, proof of address, photographic NHS number, yeah, okay. None, A, B, and C, A and B, yeah. Quite right. So most of you actually think you need something. And certainly my experience of trying to register with a GP, they want to know where I live, I just like a bank statement and everything else. The truth is that actually you don't need any of those things, as someone has quite rightly put. You don't need any of those things to register with a GP in the UK. And I'll come to why that's important in a moment. Which of the following people here, and again, put your answer in the chat, are entitled to free healthcare from a GP in this country? So is it a refugee, asylum seeker, refused asylum seekers, migrants, or undocumented migrants? So which of those are entitled to free healthcare from GPs in this country? Everyone? Okay. Good answer. Or B, some put B, or yeah, okay. The people who say all are absolutely correct. So the truth of it is, it doesn't matter what your immigration status is, your nationality, anything like that. Anybody in this country, and the same in Scotland and Ireland, Wales and Northern Ireland, they can register and consult with a GP without charge in the UK, and you don't actually need any proof of address or ID to do that. So you cannot be refused registration for not having those things. Not everyone knows that. Not all GPs know that, and certainly not all GPs receptionists know that. And this is really important because if you're living in a war zone and you need to escape from that to protect your life or protect your family's life, the first you think about is I must remember to take my passport because when I get to England, I'll need it to register with a GP. So most asylum seekers do not have any documents that would show their ID, no photographic ID or proof of address, for instance. So it stops them from being able to register if you have that. Also, there are actual genuine fear that they could be reported to the Home Office, particularly if they're a refused asylum seeker or an undocumented migrant. And there was a policy for a while that of trying to get us to report people who weren't entitled to be in the UK, which I don't think any GPs actually went along with. So it sort of fizzled out a little bit. And actually, this universal access to healthcare is protected by law. There's nothing the government can do about it without writing a new law. And I'm pretty sure they're not going to do that. It would not go down well, I don't think. Secondary care is different. It is a different situation in secondary care because you can be charged for secondary care according to your immigration status. So primary care is different. Secondary care, there are some things you're supposed to pay before treatment. So you can imagine that can be challenging for some patients on £45 a week as they are. If it's urgent or immediately necessary treatment, they must provide the treatment and then bill for it afterwards. So they can't sort of say, oh my God, this man's bleeding to death. Until he pays, we're not going to do anything. They've got to give the emergency treatment and then charge afterwards. But actually that can be a problem for people, and I'll come to why that's important later on. Some services are exempt. A&E is exempt. They can go to A&E free of charge. Infectious diseases exempt, and family planning are exempt. And that's not particularly for altruistic reasons. They don't want people walking around with infectious diseases, and they would like, if possible, people not to have children while they're here as well, I guess. Some groups are exempt from this. Refugee, so if you get refugee status, you can have free secondary care. If you're an asylum seeker, you can still get free secondary care. If you've been refused asylum, but are receiving something called Section 4 or Section 95 support, so that's a particular benefit that that people can claim if they are destitute. They've literally got absolutely nothing, they can get that. Looked after children, and we see quite a lot of looked after children in the asylum seeker size, minors who've come over to the UK on their own. People who are in immigration detention, so that might be people who are under the Mental Health Act or have committed a crime and are in detention. If they can prove that they're a survivor of trafficking, they can do that. So if you see a patient as an asylum seeker who has been a victim of trafficking, you should record it in the records because it gives them more rights so that can help them, or survivors of sexual domestic violence, FGM, or torture. Again, if that's revealed to you by a patient, it's important to record that. And the definitions between immediately necessary and urgent need to be clarified. Immediately necessary, it's life-saving, it's going to prevent a condition from becoming life-threatening, or will prevent permanent or serious damage. All maternity services can be classified as immediately necessary. So if you're a pregnant asylum seeker, you can refer them and say this is immediately necessary treatment. So that's fine for them. Urgent is a little bit more of a loose definition. It's any treatment that can't wait until the patient is due to leave the UK. You can take into account pain, disability, those sorts of things. If they're undocumented or a refused asylum seeker, assume that they may not be going back to their country of origin within the next 6 months, if at all. So you can still refer those patients under that urgent referral rate. So want to get your head around that. Basically, the way to think about it, I think, is anyone can see a GP. It's free. Someone's put in that without an ID and address, most GPs, receptionists will not entertain you at all. That's true. I think you're right. And that's why Dots of the World have got a really good campaign going, which can train receptionists about this and tell them, actually, you don't need it. You can just turn up, fill in a form, and you're able to be registered and see a GP in that scenario. So training receptionists is a key part of that if you're going to do that. Any other questions at this point? If you put your hand up or shout out if you've got anything before I move on. Okay, fine, I'll move on. So we're going to move on to some health problems that you will find if you're dealing with asylum seekers or refugees. We're doing for time, we're okay. So there are some major differences between mainstream practice. Now, I've worked in mainstream practice as a GP for a long time. I did 20 odd years as a mainstream GP. I've only worked in inclusion healthcare for a few years, and it is really different, I have to say. It's very interesting. FGM is much more common in asylum seeker populations, and I'll go into the countries where that's more likely to be the case, and a little bit about that later on in a later slide. You're going to see tropical infectious diseases, things that you don't normally see in the UK, and again, I'll go over those in a bit more detail. One thing you will also see is a lot of late stage or unmanaged presentation of chronic diseases. So people with hypertension, diabetes, heart disease, it's either not been diagnosed, or if it has been diagnosed, it's not been treated in the country of origin. So you're going to see a lot more of the complications perhaps from those diseases at a younger age group than you might do in the normal UK population. Mental health, big area. There's a high incidence of mental health problems. There's been a lot of trauma, perhaps in the home country, perhaps during the journey to the UK. And once they get to the UK as well, a lot of stress, pressure to deal with it in this country. Depression and anxiety is really common. If we talk to the patients in our practice, 70% of our patients report some kind of mental health issue amongst that asylum seeker population. We see a lot of post-traumatic stress, a lot of psychosomatic presentations relating to those mental health issues. So again, cultural differences. People may not talk about mental health in the same way in their home country. So you might get chronic pain, abdominal pain, those sorts of symptoms, slightly vague symptoms, and often with a mental health problem underlying them. So it can be quite challenging having to sort that lot out in a normal GP consultation. Other differences, the social considerations. So housing is often, if it is provided, is often very poor quality. And this picture here is a typical example of sort of housing that asylum seekers get. It's not all living in 4-star luxury hotels, as you would think if you read the Daily Mail. It's provided by Serco, which are a big private company often involved in running prisons, and is often inappropriate. So we had a patient who was an amputee, had a terrible journey to the UK. He was clinging to the side of a train and he fell off, and the train went over his leg and was laid in the side of the track for about 4 hours before somebody found him. And this is a man who'd been tortured and abused in his home country. Arrived in the UK and he put in a 3rd-storey room with no lift. I didn't have any wheelchair. He had to get up and down stairs on his crutches. As you can imagine, he just basically stayed in his room all the time because it was really hard for him to get about. And not surprisingly, he got quite depressed as a result. There are financial issues. That £45 a week doesn't go very far, particularly if you need treatment, and we get all our asylum seekers or our refugees to fill in one of these HC1 forms. And this is good for any patient who's got financial difficulties. If you've got someone who's really struggling financially, they can fill in one of these forms and they'll get free NHS prescriptions, free dental treatment, free sight tests, any of those sort of things, the usual things that you might have to pay for in the NHS. So good advice for anyone who's living in deprivation, and you can count asylum seekers and refugees in that. You get cultural differences. People have different religious beliefs to you. They may dress in different ways, speak in different ways, different attitudes to gender, etc., and religion, and you need to be aware of those and be sensitive to those. People are often lonely. You can see this man here just sat in his hotel room. Staying in a 4-star hotel might sound quite nice, but if you're in there 24 hours a day, 7 days a week, you can get quite isolated. And then the patient I was just talking about, the amputee, he'd been initially sighted in Derby with a group of people from his home country and had felt quite settled because he could speak his own language and made some friendships. 24 hours notice, they just decided to move into Leicester, and he didn't know anyone in Leicester and was totally isolated when he got here. He couldn't talk to anyone because nobody spoke his language, and he ended up self-harming as a result of that. So it's very difficult for people to adjust. The trust issues are also a thing. Some of these people have been abused by medical professionals in their home country as part of torture or abuse from the state, and so they often find it difficult to trust authority figures, particularly health practitioners. You may need to work quite a way to build that trust up. They're involved with the legal system really often, particularly if they're appealing against a decision against their asylum seeker status. And I don't know about if any of you have had any dealings with the legal system in the UK. It's pretty complicated for everybody. Imagine coming from a foreign country and having all that trauma, all that stress, and having to deal with it. It's also often really illogical. They don't understand why they're going through this process. So all that's going on. So what should you do? You're in your practice and a patient comes in, they're an asylum seeker, you're the first doctor that they've seen in the UK. What should you do about this? Really important for someone in the practice, it doesn't have to be you, it could be a healthcare assistant or another member of staff, to explain how the NHS works. There is nothing like the NHS really anywhere else in the world, and the idea of primary care as a really big service as it is in the UK is quite unusual. It's not something you see in many countries. Doctors of the World, the charity I mentioned, and I'll give you a link to their website later on in the talk, produce leaflets in every single language available, I think, to explain how the NHS works, what GPs do, what pharmacists do, when you would go to A&E, when you'd go to hospital, have referrals for secondary care work, etc. So it's really good to give one of those leaflets to the patient and just talk through how you get appointments, how you get to see somebody. Check they're up to date with the UK immunisation schedule. Almost certainly won't be, and if they're not, make sure they have their vaccinations, flu vaccines, COVID, all those vaccines that they will have not had, measles, MMR, the lot. Just get them on those vaccinations. Dental health is often really poor. Dental services in some of the countries that we're coming from are not great. Diet maybe hasn't been great. They may not have had good access to toothpaste and toothbrushes over the last few months. So checking dental health is important. And it's a really common presentation is toothache, dental abscesses, and knowing what to do to get them to see a dentist is quite helpful. Check their ethnicity and make sure you record it and make sure it's right, because there are different levels of ethnicity. You've got to make sure you've got the right one documented in the records. So Iraq is a good example. There are lots of different ethnic groups within Iraq. So making sure you record the right ethnic group is important because it has an impact on what interpreter you might need. And I'll come to a little bit about interpreters later on. Check lifestyle. Don't assume that because someone's come from a traditional Muslim country, they're not taking alcohol. Cigarette smoking is much higher in the Middle East than it is in the UK. Are they taking drugs at all? That may be the case, particularly if they've had to sort of mix with some fairly difficult characters on the way over to the UK. Sexual health is important. Don't avoid asking questions about that. You should be screening for sexually transmitted infections and thinking about HIV, particularly in people from Africa, but some other countries as well. If they're sexually active, think about testing for chlamydia, particularly under the age of 25. offer an HIV test if they're in a high-risk group, depending on what country they come from or on their sexual group, for instance, or if they're coming into the practice and you've got a high prevalence area where you're working, you need to think about testing for HIV at that time as well. So again, with every patient, so it's a blanket approach to all patients, that I would say. Women's health, women have a really difficult time of it in the asylum seeker process. Most asylum seekers that come to the UK, are over 70% of them are male. The minority of the women who come here often have been victims of sexual violence in their home country, on the journey, and often when they get to the UK as well. FGM, as I said, is a higher risk. Contraception may not have been considered. It's unlikely that they've had cervical screening or breast screening. So really important to go through these issues with women and do so in a sensitive way, and make sure you're considering gender issues in terms of the member of staff who may be doing that. Nutritional concerns, vitamin D deficiency is almost universal, I would say, among our patients. We test all our patients for vitamin D, and often it's at the lowest possible level. There are some other vitamin deficiencies. Vitamin A is common in quite a lot of groups, and not something you come across in the UK normally. And I'll talk a bit about that later on. And then long-term conditions, as I said earlier, often undiagnosed, often in younger age groups than you were used to seeing in the UK. And so screening for diabetes is quite important, checking cholesterol levels, blood pressure in people who may not normally consider it because they seem a bit young. Okay, so that's what you should be thinking about doing with every patient who's new to UK. I'm not suggesting that you as a GP does this, but the GP practice should be set up to offer this sort of a service. And in the assist practice where we work, we have our nursing team would do 90% of this for us as part of a new patient medical. So your new patient medical that you would offer to all patients needs to be expanded a little bit to include some of these ideas. Go through some specific health conditions now. Think about the countries where that's important as well. These are where asylum seekers come from to the UK, and this is a real movable feast. Every year it's different. At the moment, most asylum seekers are coming from Albania. There's a big chunk coming from Afghanistan, and we're starting to see larger numbers coming from Sudan at the moment with the problems that are happening there. If I was giving this talk a year ago, Iran was the commonest source of asylum seekers. So it changes really frequently, but these countries here are very much countries that are often in the top 10, the names that you see here. Afghanistan, Albania, Iran, Iraq, Syria have really been common for a while. Eritrea in Africa as well. You'll notice that Ukraine doesn't appear on the list there, and there's a good reason for that. There's a lot of people who have come from Ukraine, but they've not come as asylum seekers. They've been granted refugee status straight away, so they've come straight in. They haven't had to go through the asylum seeker process, so they've been given a bit of an advantage. You could think about why that might be later on, perhaps. So just some specific conditions to think about in a bit more detail. I mentioned tropical diseases, any tropical disease, but the ones you're going to see more commonly, malaria is something to consider. Undiagnosed malaria, you're going to see that in African countries, so it's very common in Eritrea, but also some parts of the Middle East as well. They've got high rates of malaria. So if you're seeing a patient with maybe jaundice, anemia, abnormal liver function, fevers, think about malaria as a possible cause of that and do a screen for it. Typhoid is quite common. It's common in the Middle East, common in Africa, common in Ukraine at the moment because of the damage to the sort of infrastructure there. And it's a very high risk in Afghanistan. So people coming with diarrheal illness, usually by the time they get to see you in primary care, they're recovered from that. But if you've seen someone who's just arrived in the UK, that might be an issue. Parasitic infections are common, and 20% of migrants who come from endemic countries will have helminth infection on arrival in the UK. And if you ever do a blood test and find raised eosinophil count, then think parasites. In a normal mainstream GP practice, you see a raised eosinophil count, you probably file it without even reading it, I would say 90% of the time. But in our practice, if we see raised in this eosinophil count, we're thinking of parasitic infections almost entirely. Schistosomiasis, which is not very easy to say, but I managed quite well there, affects 20% of travellers and residents of sub-Saharan Africa. So that's the infection you get from the little snails in the water, and the parasite, when people swimming in infected water get the parasites swimming through their orifices, and it can cause hematuria, it can cause all sorts of difficult issues. If it's untreated, you'll see a raised eosinophil count in patients with that, but you'll also see dipstick hematuria perhaps in a new patient. So think about that diagnosis is useful, and you can get a test for it. You just send off a blood test for that or a urine test. HIV and Hep B and C, Africa, really common, really high rates of HIV and hepatitis in Africa, but also in Albania, which, as you saw there, there's a high number of asylum seekers coming from Albania, Afghanistan. In Syria, Hep B's high. We don't know about Hep C in Syria because they don't really test for it. And Ukraine has very high rates of Hep C compared to the UK. So we're seeing patients from those countries. Think about that. We generally screen all our patients for all bloodborne viruses when they arrive in the UK, regardless of where they've come from. And we've got permission to do that from the local laboratory. HIV is pretty low in Middle East countries, but we still test for that anyway. TB, that's particularly common in African countries, but Afghanistan and Ukraine as well has very high rates of TB. We do a blood test for that in the practice. We've got permission to do the test in the surgery, but just thinking about it and just checking the history, looking for any signs or symptoms of it is really important in migrants. Polio. Now, when I gave this talk recently, someone said they thought polio had been eradicated in the world. It more or less has, but apart from in Afghanistan, where it's still endemic, and there's a wild form of polio that's emerged in Syria as well. So you're seeing patients from those two countries, they may have polio. Think about muscle weakness, fatigue, those symptoms that we probably learned about in medical school, because we never ever see it in clinical practice. I've totally forgotten. I mentioned vitamin D deficiencies. Vitamin D you're used to dealing with in practice, I guess, fatigue, all those symptoms that you get. Vitamin A is really uncommon in the UK, but common in Iraq and Eritrea, and it causes dry eyes, night blindness. It can cause increased susceptibility to infections, and mortality from infections is much higher if you have a vitamin A deficiency. You can't test for it. You can't do a blood test for vitamin A. It won't work, but if you suspect it, you should refer to secondary care to get that investigated. So if you've seen someone with any of those symptoms and you can't work out what's going on, think about vitamin A. And an FGM, particularly in Africa, sub-Saharan Africa particularly, but it is around Middle Eastern countries as well. Some Middle Eastern countries, some ethnic groups, it's carried out. We ask all our female patients about it, obviously in a sensitive way. You need to record it in the notes if you detect it, if the patient admits to that. And if they're under the age of 18, you should be considering reporting to the police. That's the legal situation there. And it's just being aware of it, and just there's obviously lots of sensitivities around that, but make sure you record it if you find it. Okay, what are we doing for time? Not bad. So any questions on those typical diseases? There's a question here, are you entitled to register with any GP surgery that you wish to, regardless of postcode of address? That's a really good question. Yes, I don't know the answer to that, actually. I don't know. I think if you don't need proof of address, then probably, yeah, you could just go in and walk in. Why would you want to, I guess, the answer, if you need somewhere local? I mean, Babylon sort of got around that a bit, but allowed people to register from anywhere, I think. Good question. We're trying to encourage our asylum seekers to register at a local GP surgery. We only allow patients who are in the Leicester area to register with us, although we have got some contracts with Loughborough and South Wigston as well. Okay, so any questions about that bit? Okay, if not, I'll move on to working with interpreters, which is a big part of my day if I'm working on the asylum seeker side. So, question for you again. If your patient doesn't speak English, which of the following would be appropriate? Would it be appropriate to speak loudly and slowly in English with a bit of an accent, which is something I've tried on a regular basis in France and works quite well for me? I've always managed to get the food I wanted. Would you recommend using a professional translation service, and a family member to translate, a community leader to translate, or using Google Translate? So which is the correct answer? Which of the, you can choose as many as you want. Professional, B, all, yeah, okay. including the speak loud English with an accent. Yeah. Okay. Yeah. Okay. So most are going for B. The reality is actually the recommendation is you should use a professional interpreter. That's what you should be doing, and I'll go into the reasons why that's important in a moment. But actually, apart from A, which I don't think you should do, but any of the others can be useful in certain situations. So if you're in an emergency situation, there's no way of getting hold of an interpreter, and you just desperately need to know what's going on, then yes, use a family member, use Google Translate if you need to, use a community leader. But in general terms, I would say professional translation service every time. And there's a good reasons for that. If you're going to do it, you definitely need double the normal time, at least in that appointment. Trying to fit in an interpreter consultation into a normal 10-minute slot is impossible. And if a practice is asking you to do that, then dig your heels in and say, absolutely no way am I going to do that, because you will get yourself into difficulties. You cannot rush an interpreter consultation. So you need at least double. We have 30 minutes for our interpreter consultation in the practice, and very often we'll use the full 30 minutes, I would say. Find out what the local arrangements are. They're going to be really different than wherever you're working. Every practice can have a different arrangement for this. We use a telephone interpreter service. Most GP surgeries would use a telephone interpreter service, and I think that's quite a good system. It's accessible. You can get hold of any language, sort of any time of the day. You're not having to book an interpreter to do so. I think it works quite well. But you may find there's different arrangements in different practices. In some practices, there's a particularly large population from in the local community. They may have provided a professional interpreter to help, but I guess most are using telephone interpreters. If you're not, put something in the comments. I'll come back to that later on. Check what language you need. That sounds obvious. But the dialects are important too, and that's why I mentioned earlier about recording the ethnicity really accurately. If you've got someone who's Kurdish, they will speak Kurdish, you would think, but there's also something called Kurdish Sorani, which is from a certain part of Iran, and if you haven't got the right Kurdish Sorani interpreter, then they won't be able to help. So Kurdish won't work, it needs to be Kurdish Sorani. So make sure you've got a dialect recorded, and if you need to get the receptionist to check with the patient or check yourself before you start, I think that's a good idea to just double check you got it right. Check if there's a gender requirement. So does the patient prefer a female interpreter or a male interpreter? You can ask for that when I go through the process. I can request male or female when I do that. Most patients don't mind, but it's just an option to have that. Before you start, I would always allow a bit of time, if you can, before the patient is in the room, to talk to the interpreter for a number of reasons. One, if you're going to be using any jargon or medical terms, just check that they understand them. And so I'll often just talk to them, I'm going to be talking about this. Do you have any questions about that? Is there anything you'd like to know? This is what I'm going to be talking about with the patient. So I'm allowing the interpreter a bit of time to prepare, maybe think about the words that they may need to use in that process. I also need to check that there's no conflict of interest. So do they know the patient? So even if you're using a national telephone line, some of the communities that you're working with are quite small in the UK, and there's a chance they might know the person you're translating for. So just double check, do you know this patient before we start? If not, you're going to have to try and get another interpreter. And then record the booking number. So they should give you a booking number. And I would then write that in the records immediately. I write it before I forget, because if you forget, it's a nightmare. You can never go back to it. Because if there's a problem with that interpreter, it turns out the interpreter wasn't doing it properly, and you've misinterpreted some information you've given as a result of that. Unless you've got the booking reference, it will come down as your fault rather than the interpreter's fault. So just make sure you record that. And there's another reason why it's useful, which I'll come to in a bit. If you are doing the briefing of the interpreter, just say to them as well, if you need to stop at any time, it's fine, just tell me. A lot of interpreters have also been through the asylum seeker process before they've been given refugee status, so they're refugees, which means they may well have been through quite traumatic experiences themselves on the way to the UK. So if you then have a patient talking about a traumatic experience like torture or something like that, or rape, and the translator has been through that, that can be quite triggering for them. So I always say to them, look, if you need to stop, just tell me and we'll get another interpreter. So you need to look after your interpreter a bit as well. During the consultation, it's really tempting when you have an interpreter in the room with you to refer to the interpreter rather than the patient when you're asking your questions. So it's really important that you keep eye contact with the patient when you're asking questions, even when you're asking in a language they don't understand. If you're using a telephone interpreter, don't look at the telephone. It's nearly, I've observed a lot of consultations where people do that. You tend to look at the phone when you're talking to the phone. Keep your eyes on the patient. The patient will almost certainly be looking at the phone, but occasionally they'll look up, and if your eyes are on them, it just helps them to feel reassured that you're interested in them. So try and resist the temptation to look at the phone or the interpreter. Chunking and checking, which is something you may have heard of. I'm sure you've been taught about it in Breaking Bad News and all those sort of things. It works really well in interpreter consultations. So just use really short sentences, clear language, don't make it complicated, and then get the interpreter to interpret small bits and then come back to you. Most interpreters are used to the doctor giving a load of information to interpret in one go. And so they'll often hesitate when you stop sort of after one sentence. So I just say, please interpret that, and they'll do that. What you might find is that the interpreter talks a lot longer than you thought they're going to do. So you give quite a short piece of information, and then you hear the interpreter and the patient talking for quite a long time before they come back to you. Don't worry too much about that. I mean, I used to think, what are they saying? What on earth are they saying? Why is it taking so long? They're translating stuff I didn't say. Actually, what I spoke to an interpreter about this, and they said, it's partly they've got to build a bit of rapport with the patient as well. So they're having a bit of a conversation maybe about something else, just to build a bit of rapport, get the patient relaxed, get the patient able to talk to them and reveal stuff. So that's what's going on when you hear that. It's not necessarily a bad thing. Chunk I've mentioned. Slow down, and then slow down a bit more than you normally would. So just try and take your time. Don't rush through this. As I said, make sure you've got enough time to do it properly, or else things won't go too well for you. Distractions can be difficult. If you're on the phone doing a translator conversation, so you talk to the patient talk to the interpreter and the patient are having a conversation. If you've got one of these headsets on and your computer keyboard in front of you and they're talking for quite a while, the temptation is to sort of wander over to system one and maybe start doing a few path reports whilst the conversation's going on. I'd caution against that. It is tempting, but actually you might miss change in tone. So sometimes you'll hear the conversation gets a bit more heated, or the patient becomes clearly quite upset or agitated. Sometimes the patient has suddenly started speaking English in the middle of an interpreter conversation. It's because they're unhappy with the interpreter, or so they want to say something they don't think the interpreter will understand. And if you're distracted, you might miss that. So try to avoid that. I don't wear a headset now. I used to wear a headset all the time. I've stopped using it because I found I was too tempted to start typing as they were talking. And I use a normal phone now, and it stops from doing that. And remember that half of what the person is told is forgotten, and half of what is remembered is misunderstood. And that's particularly true in translator consultations. So get the patient or the interpreter to tell you about what you said. So teach back. What have I told you? Just want to go over and make sure you've understood what I've said to you. Can you just tell me what I've asked you to do? Tell me what we're going to be doing next. Just double check that they've got that information correct. Particularly important in interpreter consultations. And then finally, after the consultation, when you've put the phone down, just check if the interpreter's still there. Was there any aspects that weren't clear? Was there anything they want to tell you that they didn't want to say in front of the patient, for instance? That can be quite helpful. Full details, report everything, including the agency you've used, what language we're using, the reference of the interpreter. And if you're going to see the patient again in a follow-up appointment, try and book the same interpreter if you can. If it's gone well, that continuity can really help. If the patient feels comfortable with that interpreter, it'll make it a lot easier the next time you see them. So getting that reference number and saying, would it be okay for me to book you again for this follow-up appointment is quite useful. Okay, so that was interpreter consultations. There is a question here from Colleen about what's your take on asylum seekers' request for letters so they can be moved to their choice of city or to be near other people from the same area, the same language. My take is actually it probably make very little difference if you do that. The Home Office are a completely opaque organisation. It's a genuine, I think it's a genuine thing to make asylum seekers as uncomfortable as possible. As a way of almost distracting people from coming. It really doesn't work, and it just creates a load of misery. my advice would be to write a letter. Just do the letter. You're there to support the patient, and I think they will feel more supported if you agree to do that letter. You may get quite a lot of requests for that. I'm realistic with them. I'll tell them I don't think it will help, but I'm happy to do that if it helps at all. You get that letter, you get that request every day on the basis. Yeah, I'm sure you do. One thing I do recommend is having almost like a template that you use, that you write almost the same letter almost every time, and you just change the details. They're almost the same details every time. Like you say, they need to be near people who speak their same language, or they don't like the accommodation, or they're we're used to this. It's almost a fairly standard letter that almost writes itself after a while. But if you can do it quickly, then I would recommend that you do it. And be supportive to the patient in doing so. It's not always easy. We've got loads of these to do. So I wouldn't sort of put it at the top of my priority list. I wouldn't be sort of cancelling appointments to do it. But yeah, you're going to get a lot of those requests, I'm afraid, particularly if you've got a large number of asylum seekers where you work, definitely. Occasionally I will say, I don't think it will. If someone asks a really spurious reason for it, I'll just say, I'm sorry, I'm not prepared to do a letter for that. I don't think it will help. But nearly always I will say, yeah, okay. Any other questions about interpreters? I've got about 5 minutes to rattle through post-traumatic stress. Do you want me to do that, Becca? Shall I go for it? Yeah, okay. It is pretty quick. Okay, post-traumatic stress. It's really important to think about post-traumatic stress. As I said, most of your asylum seeker patients will have been through trauma at some point in their life. Either prior to coming, obviously they're leaving a country, which is pretty horrible. On the journey, if they've been on a small boat, you can imagine it must be terrifying to cross the English Channel at night in a little rubber dinghy. And then when they get here, they get treated quite badly, not just by the state, but by local people as well occasionally. And that can make it very difficult for them to feel safe, to develop trusting relationships with healthcare professionals, as I mentioned. And that has a massive impact on everything, their physical health, their mental health, their social health as well. Post-traumatic stress is a slightly different thing on its own. So that's different to sort of general trauma that all migrants go through at some point and can affect them to lesser or greater degrees. Post-traumatic stress is a very specific diagnosis. Very rare that a patient will turn up at GP surgery and say, hello, doctor, I've got post-traumatic stress. Can you do something about it? They tend to come with other issues, so depression, anxiety, substance misuse, chronic pain, those unexplained physical symptoms I mentioned before. If you're dealing with an asylum seeker population and knowing their exposure to trauma, then ask about it and just say, what has happened to you? This can be a really useful question to use, and then will reveal the trauma perhaps that's causing their issues. But to make a diagnosis of post-traumatic stress, they need to have all of the following. So you've got to have this re-experiencing symptom. So that means they're going to get vivid, intrusive memories of what happened, flashbacks, nightmares. And with that, they get that sense of fear or horror or strong physical sensations that go along with that. Avoidance means that they're trying to keep away from anything that's going to cause that to come into their mind again. So they may isolate themselves, they may avoid going out, they may avoid coming to healthcare centres, etc. And then hypervigilance, so they're constantly on the lookout for that incident happening again. So they might suddenly jump if they hear a sudden noise, or they might be constantly on edge when they're in the room with you. But they need all three of those to make a diagnosis of post-traumatic stress. It's going to generally, most people will recover from post-traumatic stress without, it just goes away on its own. But about a third of people get these longer lasting symptoms, and they can be pretty severe if they come on. And they usually present within a month of the traumatic event. So it's often an acute sort of presentation, this. Having said that, most people believe that it's not treatable, so they tend to keep it to themselves, and they're also maybe embarrassed or anxious about talking about it, so they may avoid it. So it's up to you to sort of identify it in a way. Those symptoms will be persistent. As I said, they're going to impair normal life. So that's what you're looking for. It's not just someone who gets a bit upset when they think about what happened. It's just someone whose life has been very, very badly affected by it. If you're dealing with children, our children can get post-traumatic stress as well. The important thing is to try and talk to the child without the parent or carer, if possible, if that's appropriate, because the care or parent may well play down the effect of the post-traumatic stress on them. So it's important to try and get a full history from the child if you can as well. Quite difficult, that not something you want to be rushing into doing if you're not experienced in that area. What can you do about it? This is really interesting to me. Firstly, reassure them because it is treatable, and if you get the right treatment, they can get better. Do assess them for self-harm. The lifetime risk of suicide is second only to depression in post-traumatic stress. So it's a high risk of suicide. So you do need to ask about self-harm or suicidal thoughts. There are lots of support groups that can help them, and I'll send some links with the final slide to these groups that can be helpful. And then you can refer for specialist treatment, and there's 2 treatments that work. Individual trauma-focused CBT, if you can get it in your area, obviously through mental health services, and eye movement desensitization and reprocessing, which is really interesting. I don't know if any of you have heard of this. This is basically a really effective, nice now recommend it as a treatment for post-traumatic stress. To me, it sounds a little bit like hypnotism, but it isn't. Basically, you get the person to think about a traumatic event, and whilst they're doing that, you get them to do some eye movements repetitively, and it causes a dissociation in the brain between the traumatic event and the feelings it creates, and it works really well. It sounds, when I was first heard about this, I thought it sounded like kind of the mumbo jumbo, but actually the evidence base is really strong, but they need to be referred for that. So I would recommend, if you see a patient, to consider trying to get a referral, find out what the referral pathway is in your area. Don't prescribe for it if you can avoid it. The prescriptions don't work, particularly benzodiazepines. It's tempting to think, if someone's talking about major panic attacks, to give out the benzodiazepines. It will just worsen the situation. It won't help them and replace them with another problem altogether. If you are going to prescribe anything at all, venlafaxine may be helpful, or sertraline. Antipsychotics can also be helpful, but if you get into antipsychotics, I think you probably need a mental health team involved at that point. Okay, so that was the final bit. That was a very quick rush through post-traumatic stress. I hope I didn't traumatise you with that. This is what we've been through, all these things, a bit about background, a bit about the entitlement, a bit about the health problems you might see, working with interpreters and post-traumatic stress. I have a question here. Do asylum seekers have to pay for the letter that you do if you do that in support? That's entirely up to practice. There's no legal requirement for you to provide this service. It's not an NHS service, so you can charge for it. I would say don't charge for it. These people are living off £45 a week, less if you're in a hotel. I think it's nicer not to charge for it, but that's a practice decision. I can't force anyone else, and I wouldn't judge anyone who did decide to charge for it. Okay, these are some organisations. I mentioned some of these through the talk, and I'll share these slides with Becca so she can forward these to you. The ones I found most useful, Doctors of the World's got some really great training resources. And as I mentioned, the government guide on migrant health is absolutely brilliant. It's got everything you could ever want to know about countries and diseases that are prevalent there, and what tests you should do if you suspect this disease, and what treatment you should offer. It's great. If you've seen someone who's got post-traumatic stress, or for instance, who has been tortured, Freedom from Torture are very supportive, and I recommend putting patients in touch with them. And then Migrant Help UK are a good charity that really help migrants who are struggling to settle in this country, and they've got access to lots of support for them as well. As I'll share those slides so you can have a look at those. Okay, so that was my final slide, so I'll stop sharing at this point and answer any questions if anyone has any at this point. Or maybe I've overwhelmed you all.
There we go. You've got a recommendation. You did an excellent talk last year on filing investigations, and could this be repeated this year, please?
Well, I'll say with you, Becca. You'll have to ask me that one. Yeah, I'll have to see. Yeah, yeah, I'm happy to do that again.
Brilliant. I didn't see that one actually, so I'd find that interesting as well. So, thank you for that feedback.
No, I can do that. Yeah, email me. Yeah, we'll see what I can do.
Yeah.
Thanks. It was brilliant. There you go. Which one? This one or that one?
Some good appraisal fodder.
Yeah. I don't know. Actually, I'm really interested. Has anyone seen a lot of migrants? So I know that Kaleem's obviously seen a lot of migrants, asylum seekers in his area. it's really hard. You've got to stay empathic with these people. They have had an absolutely terrible experience. No matter how bad you think their experience is, it's probably 10 times worse. And they can be quite difficult and feel quite demanding, this group. And it's basically because they when they're in their wherever they're staying, their centres, everyone's just badgering, oh, you must go and see the doctor, you must go and get that. If they get that, it'd be brilliant. They'll give you money and they'll give you a house and they'll give you a car and all this. And so they come with these really false impressions. And I think being empathic and just saying, well, realistically, I don't think it'll help, but I'm happy to do a letter and see if it'll help you on the way. Because then they might tell you about the health problem they've got, or the sexually transmitted disease they've got, or the FGM they've got. And if you just say blanket no, then they're going to just back away. So I would just have a system for it, really. Yeah, hotel next to the surgery. The letters are often it's the charities that are sending them to ask for the letters as well. And sometimes the Home Office are asking them to come for letters as well. So it can be, it's not entirely their fault, I think. They're getting pushed into it. But to me, it's actually pretty rewarding. I found it quite challenging when I first started doing it. In some ways, homeless healthcare is easier in many ways, which, I don't think homeless healthcare is either easier than much, but I think it is a bit easier than asylum seeker healthcare. Most asylum seekers are quite young, actually, so they don't have many of the sort of chronic diseases that you'll see in your mainstream practice, but they have all those mental health issues to deal with, which is quite challenging. Locality graphome, yeah, so grant from local hotels, yeah. I mean, some of the hotels end up are actually quite nice hotels as well in Leicester. They built a brand new Novotel in the centre of Leicester, and it's got asylum seekers staying in it, which is, they don't like it. It's not a very nice place to stay when you've got 4 kids and 2 adults in a room built for 2.
It's things like, I never thought, and it's the same, I guess, with homelessness as well, that if you are in a hotel, you've got limited funds, but you can't cook. So you need more money to spend on food, but you've got less. So, like things like kids doing homework or having some space, people getting sleep, all those basic things that you don't think about make life, everyday life that you take for granted, a lot harder.
Yep, no, definitely. I mean, I quite like Novotel. If I ever go on holiday and go to France and I get put up in a Novotel, I'm actually quite pleased because they're really nice hotels. But they don't do Syrian food, and they definitely don't do Afghan food. And if you've got young children who only will eat food that they're used to, it's quite difficult to get them to eat hotel food. And lots of asylum seekers don't like the hotel food. And the hotels get a lot of money to accommodate these people. So maybe they could start thinking about their menus a bit, maybe. I mean, some hotels are brilliant, I've no doubt. We have some hotels, they have really good supportive staff who flag up concerns and they let us know if they're worried about somebody. But some are obviously not so ethical about it, I think, unfortunately.
Yeah, that's fabulous. I found that really, really interesting. And just the figure that sticks in my mind is 86% only cross one border. And obviously your right-wing media is always going to be biased, but even just some of the more mainstream media, they don't run with that. And and it's just fascinating. I think that view of empathy as well for what they're going through, I think, is really interesting.
Yeah, I mean, I think that we have 75,000 applications for asylum in the UK. Germany had 320,000 applications for asylum in the same period, and Germany's not that much bigger than the UK.
Yeah.
We don't hear much about that, do we?
And that's the thing, you get biased in seeing all this thing, and and you forget as well, sadly, there's a human at the end of it, and particularly I think 45% or 42% of people are displaced people are kids, who clearly have no choice or anything in their situation that they're going through.
Yeah, I think we need to be more empathic as a country, definitely.
Yeah.
And actually, I think the majority of the country actually are supportive of looking after asylum seekers, but it's just a small, very vocal minority that are making it out. It's be difficult.
Yeah. Definitely. So thank you so much. If you're able to email the slides, that'd be grand. And I'll also put the recording on our website as well, so people can look at it, and obviously they can see the resources and stuff. So that's fabulous. Thank you so much for your time. That was really good. Thank you.
Nice to see you all.
Cheers, guys.
Bye-bye.
Thank you.
Bye.
Cheers. Bye, guys.
Bye.
Cheers. Andy, so what I'll do, if it's okay, is I'm looking into booking some autumn stuff as well. So I think particularly because Kaleem had said about the investigations and things, I think that'd be great if that's okay.
Fine, yeah. Just drop us an email. Yeah, that's fine. And I'll see what dates I can do. Yeah.
Grand. Do you also, just thinking the things you mentioned, would you be interested at at some point doing a talk about your work about empathy and empathic practice? Because that's probably something that's not.
Yeah, definitely. I've got can do a talk for that as well. Yeah, definitely. No problem. I'd like to.
We'll get bless you. Sorry, we'll harangue you, but thank you. That's really good.
Okay, lovely.
Yes,
okay,
have
nice
a
to
good
see you,
night.
Rebecca.
See you
Okay,
later.
you too. Okay, bye-bye. Bye.